Now finally, this is the first video in the series on hip pain with running, and this is a series, an informational series that I've wanted to do for a very long time. Now so looking at hip flexor tendonitis, we have to take some account of some bony landmarks before we actually start treating it, because if you treat too immediately or towards the inside, towards the belly button, then we're going to have issues with, there's a vein, an artery, and a nerve which come down this way. So what I like to typically do is teach people how to find their ASIS, or the front part of their hip bone right here, so which is a really bony area. And downward from here we have the rectus femoris, and one of the quad muscles actually attaches just down from this, down here, but just inside is the hip flexor, or the iliopsoas, which you're all concerned about. So deeper into that actually is way down is the actual hip ball and socket. So when we go through typically testing for this, we want to make sure that we're not missing that it's a hip capsule injury. So again, treating further inward, you're going to get into trouble, running into vein, artery, nerve, and it can cause radiation and pain down the way. A modified Thomas test is a great way to test actual hip flexor length to see if you have actually a short hip flexor, because a lot of people don't. They just feel like it's short. So what we're going to do is we're going to actually test this side. So she's going to bring this side to her chest. There you go. So we're doing it passively right there. She's going to lock it down and then roll back, and I'll help her leg up. And now I just have to really make sure she has her trunk engaged and she keeps her back flat against the table here, because the hip flexor does pull on to that section of the low back and it can yank it upward. So now we're going to lower her leg as far as she possibly can without me pushing it down, to see if actually she goes almost further than parallel to the table here. And actually you're seeing some positive findings here. I know that we had a different camera angle, but if this pillow wasn't here, then she should get below parallel to the table. I usually test this on a different table. Now, if you notice here that she has actually the leg outward this way, bringing the leg down to 90, this is more of a negative test, which would mean that her long quad muscle, her rectus femoris, as well as her hip flexor are actually normal length. So again, if she's testing out here, the rectus femoris, which is the one which goes all the way down into the kneecap, is possibly actually tight. And again, if this was right here, but it lifted up that way even further, this would be a positive tight hip flexor or hip flexor contraction. So to confirm actual active versus passive component injury in the hip, we need to do a resisted hip flexor test. And this is just one of the few ways to do it. So the hip flexor, again, it is an active tissue. It is a muscle and tendon. So when she actually contracts, and push against my hand there, that way. So if this actually is a tendonitis of some nature of a hip flexor muscle, go ahead and relax, then she's going to feel increased sensations or symptoms with something like this. However, if I bring her up here and she doesn't even contract and she's not doing any work whatsoever, and she feels a pinch and she says that it's a duplication of exactly the hip flexor quote-unquote pain that she's having an issue with, then we really need to look deeper into the other structures of the hip, the labrum, the joint capsule, possibly a cam deformity. And I know these are large words for most people, but I will do videos on them further. So again, the resisted hip flexor test, go ahead and push into my hand that way. We also can test the rectus femoris as well, push into my hand this way at the same time. And if one of those sets it off, then it's a possibility that it is confirming of a hip flexor issue.
Now, I like to assess complex movements such as the squat and the lunge. We'll start with the squat here. We're basically looking to see if there's any abnormalities in her movements. And I know this is a very vague term, but I'm looking to see whether she shifts her knees forward in this plane. Does she lean forward excessively? Does she have sway in her back, which at this point I see a little bit of sway? Or we're looking for rounding as well at the bottom. Does she round, or the slang term is butt wink? So we're looking at all this stuff, and based upon what we find are really what the major corrections will be. So I see a lot of extension on her at this point, and her knees really shift forward, almost shifting her weight onto her toes. So hip flexor tendonitis, a lot of times it can go along hand in hand with hip as well as core issues, and also deficiencies of complex movements. Let's take a look at the other angle. Now in this angle, we'll typically look to see if she's shifting towards one side. Does she have a little bit of knee cave at all, or do her knees dive inward excessively? So those are the things I like to see here. Also to see also her shoulder plane as well. A lot of times if she's shifting to one side or leaning, then that'll mean there's some type of trunk instability as well. So that'll guide us in our rehab. Next, a lunge is important because if you're going to be running, you're going to be on one leg at some time or another. So I like to see, again, this direction, we're looking to see if there's any forward lean. Does she shift forward too far with the knees? Is she having any pain actually in the back leg, or the back thigh is extremely common as well with people with hip flexor issues. So this is something we can see here. Now, if we're looking from the front, I'm looking to see if she mainly has any hip drop. Is her belt line actually parallel to the ground? Are her shoulders parallel to the ground? Is her knee caving inwards? Are her feet and ankles turning into pancakes? There's a lot of things to assess here. And again, this is the guiding step. That's why it's called assessment. We're guiding to see how the rehab or treatments will go. We will go into some actually treatment later, so don't worry. This is just the assessment part. Now, myofascial release is treatment of the muscles, fascia, tendons of the hip flexor. And in this case, we're going to find the hip flexor, which is going to be right on the inner part of this bone right here called the ASIS, or it's the front part of the hip. You slide almost in like that, and you can almost cup it. Make sure that when you do this on yourself or you're doing it on somebody else, don't have pointy fingers. Pointy fingers are really, really uncomfortable. So in this face-up position, we can basically have her leg slide out while we're applying some pressure just on the inner part of that bony part of the hip, quote-unquote, again, the ASIS. So I like to do this a few times, and if I'm treating somebody, I like to back up my hand contact, again, using flat fingers. It's extremely important. Now, keep in mind, as we spoke about earlier, that if you go inward too far, there are vein, artery, and nerve there. Now, I'm going to show you on the other side, just so you can see how much pressure I have, my hand contacts, and I'm going to find that bony prominence over here as well, and kind of sliding in. And again, this is a really tender, sensitive area on people, and I've never, ever recommended in person that anyone use any type of device on their own to get rid of hip flexor tendon issues. And keeping that in mind, I would strongly suggest going to someone who's experienced in deep tissue work. You could find a really good massage therapist. Again, there's good and bad of every type of profession. You can find a really good person, like a chiropractor, a PT who does active release is a great one. That is also called ART. Graston technique is another good one, as well as ASTEM or instrument-assisted tissue work. So all these are possibilities of people that you can use. By the way, if you cannot find the tendon, you can press up, how I did, have her press up onto my hand. You can really feel the tendon pop up, and then you can really grab onto it and let her slide her leg down. Now the sideline technique is really good because we can actually use the fingertips even better to get in just like this. And what we can also get to is more hip extension. So I can bring her leg all the way back past neutral, which is what we can get on the table. But again, this is a little bit harder because you have to butt up against the person, make sure they don't fall off, because oftentimes they'll just roll back onto you. So we can extend the hip like that, keep pressure onto the psoas or iliacus area, and then get a little bit deeper into the area. Again, sometimes people like to hyperextend if they don't feel comfortable with you moving them, which is not what we want. So you need to sometimes keep them locked down on the table really well. And getting higher onto the psoas belly is really tough. I've had patients ask, like, can you get to the belly of it? I don't think so. It's way deep back there. So I like to focus on the tendon and stuff more towards the groin area. Now, mobilization of the hip capsule is really important with hip flexor tendonitis, mainly because the back side of the hip can be so tight that it's making the front side here work a little too hard. So what we're going to do is we're going to put her into flexion here and push the femur up a little bit so that we can now mobilize the back side of the hip capsule. So we're going to drive her up here, find a restriction, assess a little bit, and then we're going to press down the shaft of the femur, leaning into it. And right now I'm going to add a little bit more of internal and external rotation just to assess. Again, we're looking for that area that's hung up. And I feel that with internal rotation, she can use a little bit more motion. So I'm going to use my elbow to drive that in there. And again, one important thing is make sure that there's no pinching, because we're simulating almost a Scour's test. So we're driving down the line of the femur, and then we're using the elbow to endorse more internal rotation of the hip. Really loosening up the backside of that hip capsule. We're going to make it so easy for that hip flexor to move. Now, a rope stretch is still really good if we use this in a mechanism where she's engaging her trunk as she is here and then extending the hip. I think we're still in good shape, because that is one of the major problems with running. We have a lot of lumbar extension with hip extension like this, when you should be more like this. You can hold that for about 10 seconds or so, make sure you're engaging the trunk, and then take a little break. Now think of the couch stretch as doing that rope stretch now, but you're doing it from a kneeling position. So now we have gravity that's really affecting us. Put that foot up on the wall. We have the hip driving down towards that front side foot, and she's also engaging her front side abdominal wall, and now she's oscillating through that hip motion. I like to have her put hands on the hips so that she is now breathing really deeply, engaging her trunk, engaging her deep abdominal area, and using her diaphragm to make sure she's controlling the rigidity of the torso as she's going through hip motions. Again, I like going through an oscillating pattern rather than just a stretch and hold. Again, we'll take a step back just to see, and you see that she's tall as she can possibly be, hands still engaged on the torso and oscillating back and forth. I like to spend about a minute or so per side.
Now, learning how to breathe and brace, usually we have them do it at the 90-90-90 position. So that's hips, knees, and ankles. There you go. And so now at this point, we're going to have them assess first. So she's going to put her hand on her chest and her belly and chest. There you go. So now I'm going to have her breathe about 5 times normally. I'm going to slide down here and see if we can get a view. Okay, so we're looking to see if she's breathing through the chest or the belly to see which one is actually moving more. Good. So now what we typically do to correct chest breathers is we usually have them, so now they're going to go hands on the sides, like kind of just underneath the rib cage right there. Good. And she's obviously holding this 90s position. Now from here we're going to have her exhale forcefully. There you go. We get a delayed. Good. So now, usually you exhale really forcefully like you're doing it out of a little straw. Okay? So now that's going to drop the rib cage down a little bit. So I want you to actually feel your sides right there when you exhale and see how the rib cage drops and the abdominal contents really starts to tighten. Now I want you to breathe in the nose and out the mouth, and I really want you to act like you're trying to press your hands away from your sides with your abdominal wall when you breathe in. And no. So in the nose, out the mouth, in the nose. So now we can see she's really actually emphasizing chest breathing. So I want you to keep pressure onto those hands right there, in through the belly, make the belly really big, and out. And in one more time. And I'm probably going to correct this. Okay, so now I did a small correction. So breathe in the nose, out the mouth, and all I did for the correction was mainly put my hands where her hands are and told her to press into them while she breathed in and out. Sometimes it takes small external cues like that to improve breathing, but this does take a little practice anyways. Now you see there's less chest raise, as in the last one there was a ton of chest raise.
The wall bug is a great way to help engage the core, limit extension, and decrease the workload on the hip flexor. And what we like to do is have the person go almost head to the wall and put the hands on the wall and press really hard against the wall. This will help engage the front side of the core, or the abdominal wall in the front. And then we have shoulder width apart, and then we do almost like a marching pattern or a single leg squatting pattern. We usually have people do this for time. 2 minutes is usually pretty tough. Now, if we look from the side here, the reason why this is helpful for the hip flexor is because we're training the abdominal wall to keep the lower back or the torso rigid and more flush against the ground. Well, you might say, well, do I have to be all the way against the ground? No, but whatever position you pick, you darn well better stick it there, because if you don't, the hip flexor is going to lengthen and pull the back into extension or a sway back. Put the heels against the wall. The knees are obviously on the ground. And then we drop the hips down towards the heels and keep the shoulders more towards the ground. And imagine now she's squatting, but she's sideways, basically. So this helps out with keeping the knees in line with the toes, and it helps out keeping the back flat. Because sometimes when you give people weight, or they do it when they're freestanding, a lot of times they'll shift a lot to the side, or they'll put more weight onto one foot, or they'll cave the knees, and this takes a lot of that out. This is called a patterning exercise. It won't strengthen you necessarily, but it'll help your brain talk to your body and get the movements right before we actually strengthen them. Now, the seated good morning, and the reason why I chose the seated variety is because it's more of an unloaded pattern, and we have the hips in a flexed position and really locked down, so it helps train people into only moving their torso. Now, we eventually go to a standing pattern, but notice how she has her knees really wide, and she's dropping her chest forward, but from the pivot point of the hips. You should keep your hips ideally all the way on the pad or on the bench or on the chair when you're doing this. Sometimes you can put your hands actually on your torso or on your sides, the side of your trunk wall, and start to breathe in and out really deep to help keep that torso really rigid. This will be helpful with attaining the proper forward lean with running to limit the amount of sway back or extension that we have, which typically goes along with hip flexor issues. Now, going into the standing variety, we can call this good mornings, we can call this Romanian deadlifts, obviously without weight. People call it a few different things, but for the most part, we're doing a hinging pattern. We call it a hip hinging pattern. The knees are slightly unlocked. She's driving her hip back towards the window in this case, and keeping her feet glued to the ground. Her chest is then coming forward, and we're keeping the same position of the spine, keeping the same posture as she should have when she is seated, also when she's standing upright like this. Now we'll do a little bit of a close-up so we can see that backwards hip displacement, okay? The knees are not locked, and she's pressing her hips back, still keeping the spine in proper position. She does have a little bit of a sway here as well, but again, this is just her typical movements. We'll clean that up. Now, the kettlebell deadlift is a weighted variety of that same movement we just saw. Let's start with a penguin carrying an egg position. Go a little bit wider. Slide the hands and forearms through the thighs, keeping the hips above the knees, and then pick the weight up, driving the hips towards the weight. Driving the hips towards the weight or the heels or feet through the floor. Your feet should not come up off the ground at any point during this lift. Okay, it's not uncommon for people to slide forward. Now, in case you're wondering why we should be doing this at all, this is going to help hip flexor tendonitis by keeping us in a rigid trunk position. We're trying to make the trunk, torso, core very rigid so we can decrease the possibility of that being a sloppy attachment point for the hip flexor. Again, just like we talked about with the wall bug. So this is really important, but it's important to get form first, which is why I showed you those other varieties leading up to this. Then you can load it. Now in the low windmills, we're going to start in the same position. The penguin, step wide, now step a little bit to the side. She's going to slide her forearm down through the thighs, hips high ideally, fingers straight through the ceiling, and then she's screwing herself out of the ground. The ending position when you stand is the same position as the top of the last exercise, the kettlebell deadlift. Think of this as a single-armed kettlebell deadlift with a slight variation of the hips. What is the point of this exercise, you might wonder? Why are we doing this? Well, because the hips are a ball and socket. We need them to rotate like ball and sockets. They don't only move forward and backwards. Forward-backwards movements such as squatting, deadlifting, a kettlebell deadlift are again forward-backwards. So we need to train them to work in the frontal plane, the side-to-side plane, and the rotational plane. Now I'll show you from the front side here so you can see again technique and setup. Sliding down, she's keeping the hips low, they should be a little higher. Fingers straight through the ceiling and then unscrewing yourself from the ground. Notice that her chest is going to come towards me every time. She showed a faulty one there where her hand is not. There you go. She got to be all the way to the ceiling. Thanks. Now in this angle, we're going to see that the knee on the side opposite of the weight is going to be a little bit more straight. And the reason for this is because we need the hips to load asymmetrically in this. Again, it's a hip motion. The torso is along for the ride. If you have back pain, it's because you're rotating the spine. Now, a high windmill is the more advanced variety. She has to snatch the weight up, press it into the air, and now reaching down, acting like there's a weight down there, similar to the low windmills. She has to press the weight all the way up to the ceiling, okay? Notice that the hand up top is just above the hand that's below. She's looking the weight into the sky, again, rotating. She forgot there. Rotating her chest every time to me right there. Let's see a different angle. Looking the weight into the sky, going down only as deep as she can, as if she was picking up another weight. We'll pick up another weight in the next one called the low high. This is the low high. She has to snatch the lighter weight up, press it into the air, lock all those joints out, look it to the sky, and reach down between the thighs to pick up that one weight. Again, look at the weights being right over each other. This is so important in doing this exercise. All the other mechanics of it are exactly the same as the low windmill, which is why I spent so much time on that before. This is the more advanced variety, so if you can't do it, don't do it. This is a progression. We start with low windmills to high windmills to low-high windmills. Eventually after this, we would switch sides to keep it symmetrical.
Now looking at hip conditions, we really have to address the entire cavity here. The core, the back side, the front, the sides, the front side, the diaphragm, the pelvic floor, which all control keeping these things together. Let's just say, this is easy for a lot of people to understand. If I bring this up and if I contract this, say this is the rectus abdominis, it'll raise this portion, which will then affect these, which then affect muscles coming off of this and down into the hip. So another example as well is if we have, this is like the hip flexor attaches to the lumbar spine on the sides, and I'll do it on this other side so you can see. So right there, okay, it comes down and it passes right through there. And in the bony line mark example, I said that this is the spot we're looking for right here. So diving right in, you'll feel the tendon right there. But really, the hip flexor's goal is to contract and flex the hip. Okay? We want this area to remain stable right here when it's attached to the spine. The only way it can do that if we stabilize the area that stabilizes it. Okay? So if we contract the hip flexor and this side's sloppy, it's going to pull this thing forward. And you can see when I'm pulling it here, actually I'll put it on the other side so you can see, when I'm pulling it, actually it's moving the spine. Okay? And it's compressing this side, it's opening this side up, it's compressing the disc, and it's making the hip flexor work really, really hard to do what it's trying to do, which is move the hip up, right? Okay? So the hip flexor as well as the hamstring, let's say on this side here, we have it right here. Let's say it comes down this way, okay? If you have tightness in the hamstring and we're rotating this thing up, this whole ilium, we're rotating it up right there on the back side though, right there. So what's happening is it's stretching this hamstring and it's making it feel tight when we really have an issue mainly with this thing dropping forward. Again, how do we address that? Well, we need to make it so we're working the things which can elevate this up which will put this in a better position. Now, it's not only the rectus abdominis, like I'm demonstrating here. Actually, that's one of the least ones of our worries. It's the ones on the side. It's the deep core. It's the diaphragm. It's the pelvic floor. It's things that actually the air pressure in here as well. We call it intra-abdominal pressure, which is why we focus on breathing bracing so much in the office here. So if you have more questions on this, I have an entire section on our podcast on hip. I have hip experts. I have hip rehab. I believe it's in the high 20s, but there's a few industry experts they explain it very, very well, and we're talking mainly about this part. So if you have any questions, feel free to contact me on p2sportscare.com. Again, the podcast is p2sportscare.com/podcast. I'll put some links below in this video. Talk to you guys soon.